Hello and welcome to your online lecture for suturing or wound closing. Sometimes those terms are used synonymously, but really I want to use wound closure because we can talk about the different ways in which the wounds can be closed. One of those ways can certainly be through suturing, but a steri-strip is also a form of wound closure as well. This will be a three-part series of what we call our advanced athletic training skills that the program will teach you. So the first advanced athletic training skill will be wound closure, the second will be casting, and then the third will be IV in no particular order. Today we're going to focus on wound closure, and I get excited when I think about this because really we're entering into what we call as interdisciplinary medicine. The ability of an athletic trainer to know what suturing is, to understand what's required of it, to actually be able to perform it, really just places the field of athletic training in a different realm when it comes to interdisciplinary practice. I do want to give a disclosure, however, that you guys are students, you are learning this skill in a class-like setting. So I want to be clear on this because I've been asked, completion of this class does not result in a certification for suturing, which means you shouldn't go to your clinical sites and volunteer to suture an open wound. And then as you get ready to leave us, I think more importantly, understanding that the rules and the laws for suturing, in particular as it relates to athletic training, will vary. So if you move to a different state, you need to know your state practice acts. In the state of California, athletic trainers cannot suture and cannot work autonomously and independently in wound closure techniques that involve needles and anesthetic. They have to work under the direction of a physician. So I want to make that very clear. Now that that's out of the way, let's go ahead and get into why we are doing this as a program, right? Dr. Cosby, if we can't do it independently and autonomously, why are we doing it? Well, there's really two reasons. One, we have to. But two, more importantly, I really think it allows you to understand how the body heals, what happens to the body when wound closure occurs, and it prepares you to work in other settings outside of the traditional field of athletic training. Some of you may want to work in the hospital setting where you'll have to remove sutures, right? Some of you may want to go and work as a physician extender. There's many reasons that we are teaching this, but the major reason is because our Commission on Accreditation for Athletic Training Education, or CATE, changed our medical standards, the standards that we're supposed to teach you and prepare you for when you leave our program and when you take the exam. And one such standard that is huge is standard 70. And so it says, and I'll just read the first sentence and then I will talk about how that applies to this particular lecture today. Evaluate and manage patients with acute conditions, including triaging conditions that are life-threatening or otherwise emergent. These include, but are not limited to, the following conditions. And we're going to skip all the way down here to this bolded underlined component where it says wounds, which includes care and closure. And closure is a very broad term. We can use, like I said, steri-strips or dermabond, and suturing is a part of that broad scope of closing a wound that is open. You can also see that we've already hit some of these in your current class, right? That CPR, supplemental oxygen, and suction. So we will kind of hit each of these in different courses along the way. But today, the focus is on suturing. So one of the questions you always have to ask yourself, and if you're worried about, litigation, if you're worried about whether or not you should be suturing, the question is why? Why do we suture in particular? Not do we wound close, but why do we suture? And there are really four medical reasons that one should be suturing. In the field of athletic training, the one that I think most often applies to us is to facilitate faster healing, right? If we can facilitate that faster healing, that patient is able to return to play quicker and everyone's happy, right? But there are other emergent conditions such as a large open gaping wound, and we need to control that external bleeding. So we'll do it to control bleeding. We do it because open wounds we know are at a higher risk for infection. And so we want to close that wound to reduce the risk that pathogens can invade it and cause an infection. And then last but not least, particularly in the face, to minimize scarring, right? We always want to have a face that is scar-free. So one of the ways to minimize scarring is to actually suture. So before we can actually talk about the technique of suturing, we have to go through a few different things. And I know sometimes the things we have to get to the fun can be boring, but these are things that are important because if you understand the anatomy if you understand the different types of wounds that we can experience in the clinical setting, then it makes suturing easier. At least I find it that way. So as we think about the wound anatomy, we have to understand the layers of the human skin, right? And there are really 4 layers that are of concern. And the first layer that and the most superficial layer and the most visible layer is going to be the epidermal layer. And then just deep to that is going to be the dermis. The hard part with the epidermis and dermis layer is they are so tightly adhered to one another. So they have this really close and direct relationship that most often, if the epidermal layer is injured, you subsequently kind of injure the dermis. Similarly, when you're suturing, it's typically pretty hard to suture just the epidermis layer. You typically get some of that dermal layer in there as well. One of the great things about the epidermis and the dermis layer is they provide the strength and integrity of the actual wound. So when we suture, we want to make sure that we have both of these layers in there because it's going to strengthen that wound, but then also create an alignment. Have you ever seen a suture that was kind of jagged? One of the reasons that it's most often jagged is we don't get both the dermis and epidermis, and so the wound is weaker, and as it's healing, it stretches, and it doesn't align as well, right? Hopefully that light bulb's going off in your head. And then we have the bottom 2 layers, which I haven't spent a whole bunch of time on, but we'll do that now. So we have the sub-Q or subcutaneous layer, and then we have the muscle layer. Now, suturing these 2 layers doesn't add to the strength or integrity of the wound, but what we've seen over time, particularly with plastic surgeons, is that even though the wound doesn't involve the sub-Q or muscular layer, they will also suture those layers as well, because what they do is they provide better cosmetic results. So they're not going to add to the strength or alignment of the wound, but if you have a facial injury, for example, and you really truly want better cosmetic results, then you suture the sub-Q and muscle layers as well to create a better looking wound. So those are the 4 layers of the skin. Now let's talk about the different types of wounds that can actually happen to the 4 layers of the skin. Kind of think of this as like a sprain or a strain grade 1 through 3 model. You can have a superficial wound, which is just going to involve the epidermis. But again, remember, if we go back a slide, even though it only involves the epidermis, most often we're going to suture both of these layers because we want to create that strong, right, foundation, and we want that wound to also be aligned. We have a partial thickness wound, which will include the epidermis and dermis, which is okay because most often we're going to suture both of those together anyways. And then we have a full thickness wound, right, which will include all of these layers. So the epidermis, the dermis, sub-Q, and the muscular layer. These are, gunshot wounds, knife traumas, for example. Those are going to be wounds that would probably plague all 4 layers. Very rare that you see a full thickness wound in the field of athletic training, but it can happen, right, with also maybe compound fractures, for example. So there are 3 different types of wound closure techniques that we are going to use that kind of go hand in hand with the wound healing. Those 3 types are primary, secondary, and tertiary wound closure techniques. And I think the name actually describes what exactly is happening and when exactly we are actually closing the wound. So I'm going to go to the primary wound closure first. This is a wound where the edges are very clean, where there's very little debridement required of that particular wound. So it's a clean wound by its edges. It's pretty clean from an external factor. And so these are wounds that are closed immediately. Most often can be closed with a suture or a staple, a steri-strip, or dermabond, depending on how deep, right, that injury is. So if we have a wound, for example, that is a superficial wound, it can be closed immediately. And most often, if it's superficial, we can use dermabonds or steri-strips, right? Because it just involves one layer. If it is a partial thickness, maybe that's the epidermis and dermis, probably going to need sutures. Staples most often are used in areas where the skin is really tight. So most often we see staples being used on the head most often. So with a primary wound closure, a wound closure technique that's done almost immediately after the injury, once the injury has been debrided. What we can see with that is the beauty of this technique, particularly with full thickness tears is that they can heal within hours if you repair them quickly, right? The other beautiful thing, particularly with the full thickness wounds, is that there's minimal scarring, right? And that goes back to what we said in the other slide is, remember that epidermis dermal layer is going to provide the integrity and the alignment. And then if we have sub-Q in there and muscle, not only will it provide alignment and strength, but we also know that those are going to minimize scarring and create that better cosmetic effect. The other thing about primary wound closures, we get minimal scarring because we close up the wound quickly, and so you don't have as much tissue being able to form around the injured state. Does that make sense, you guys? Hopefully. Okay. Most of these wound closure techniques that we talked about, the patient is okay to shower. The exception up with that would be dermabond. Typically, you'll have to cover that so that the dermabond doesn't lose its tackiness to the actual wound itself. So here's an example of a primary wound closure. So we are presented with a full thickness wound, right? You guys can see the epidermis, maybe dermis, sub-Q, and then you have muscle. So we have a full thickness wound. And then eventually what we do is we primarily close that. And so what we'll start to see is an earlier suture will create a cleaner wound, which will minimize the scarring, versus if we don't do the primary wound closure right away, then what we get is some scarring that occurs. Still minimal, but we get some scarring there, which creates a harder wound and a wound where the skin isn't able to move as much, which ultimately impacts range of motion, for example, for patients. For secondary wound closures, typically this is a full thickness wound that we're dealing with, right? So remember, it's going through all 4 layers. Essentially, we allow that wound to kind of close and heal on its own. In other words, that wound is left open to heal. In the field of athletic training, I think of compartment syndromes when I think of this. So I've had an anterior compartment syndrome where they've actually had to do a fasciectomy and open up the anterior compartment, and you don't want to close that wound, right? Because if we close that wound and we don't allow it to heal naturally, if we close it too soon, remember, a compartment syndrome, there's swelling, there's pressure, and so that pressure can impede upon the vascular structures and actually make things worse. So there are times where we actually want the wound to close, and so this is called a secondary wound closure. We allow that wound to heal. Essentially, what we also allow it to do is we allow for that inflammatory response to kind of take place. In other words, it's going to get larger before it gets better. But through this process, there's a healing that occurs. And we'll talk about these 4 phases in just a little bit. But the beauty of this is we allow the wound to do its work. We allow the body to naturally heal itself, and we also reduce the risk of secondary injury as a result. The secondary wound closure technique is most often used for dirtier wounds. So for example, wounds, let's take a track athlete who maybe has maybe a compound fracture and lands in the sand pit, right? We kind of don't want to close that wound right away. We want to reset the bones, but maybe we don't want to close that wound right away because we know that there's small granules of sand in there. And so then the risk of infection is relatively high. Leaving that wound open allows us to do multiple debridements. And so a secondary wound closure, I've given you examples of that. Most often it's a full thickness wound where we want the wound to heal on its own. And there are advantages of that. The body learns how to respond to injury and to healing. And so that's secondary wound. And then we have tertiary wound closure. And this is called delayed wound closing. So this occurs when the wound edges are not reapproximated immediately. So in other words, we don't suture immediately. We don't do the primary wound closuring. And then the wound is allowed to remain open for about 3 to 5 days. And then it's closed. And there are reasons that we do this. The major reason, it goes back kind of to that secondary wound closure where if we have a wound that might be susceptible to an infection, we'll debride it multiple times. And then if we think we can if we think that through the secondary wound closure, if the body heals itself, the edges won't reapproximate or align. Does that make sense? Then after 3 to 5 days, we'll go in and we'll suture that wound. What we know about this is typically By the 4th day or so, phagocytosis is underway. So the process of healing is underway. So we're out of the red area of increasing the risk of infection because the white blood cells have started to come in and started to heal that wound so we can close it. And then typically this type of wound closure is most often done with some type of surgical suturing. So that patient is actually probably going to go under, and then the physician will suture, debride, and then close that wound, and they'll have to reapproximate. By reapproximate, they may have to adjust the skin a little bit so it's aligned. So again, a tertiary wound closure is one in which we do allow that open wound to kind of heal and remain open for 3 to 5 days. I would say the biggest difference between tertiary and secondary, in a secondary wound, and I didn't say this, but in a secondary wound, those edges will approximate to one another. In other words, those edges are clean. Once that wound heals, you'll have a very beautiful looking scar. In a tertiary wound closure, we have to assist the skin a little bit to realign. Otherwise, you'll have a very jagged or a very ugly scar. So those are the major differences, right? Primary, we're going to do that right away. We're going to close it right away. And there's different ways that we can close it. Secondary, we're going to allow that wound to heal itself. The wound is left open. Most often there's some sort of plastic, protectionary piece that is placed over that wound, and sometimes they'll use a little bit of a suction to help close the wound, but it closes on its own. And then you have tertiary, where we leave it open. It's a combination, right, of secondary and primary. We leave it open for 3 to 5 days. We allow phagocytosis and the white blood cells to come in and start healing, and then that wound is just so jagged that we need to reapproximate it by suturing. And by suturing, I mean actually suturing the wound closed after 3 to 5 days of initial injury. So in the secondary wound closure slide, I said a little bit about the fact that wounds go through a phase of healing, and these are going to be important. We'll talk about them again. You'll hit them again in therapeutic modalities, but this will be your introduction to it, a brief introduction to how a wound actually heals when a patient has a wound. So there are 4 phases. We have hemostasis, as the name implies, some type of blood being static and maybe moving. We have the inflammatory phase, the granulation phase, and the remodeling phase. And so if we look at each of these phases, one thing that I hope you're kind of seeing with the red, orange, blue, green boxes is that they overlap, right? So part of wound healing, even though it's broken up into different phases, there are overlaps between the phases as some of the phases are simultaneously occurring. Does that make sense, you guys? I hope so. All that to say, wound healing is a continuum. That's what I wanted. So there are 4 phases of wound healing that we're going to talk through: hemostasis, inflammation, granulation, and remodeling. I think one thing to kind of keep reiterating over and over and over again is that even though the stages of wound healing proceed in a very organized way and follow these 4 steps very succinctly, I think it's important to understand that a wound can certainly progress backwards or forward, depending on the external and internal kind of conditions of the patient, right? If a patient gets an infection at some point in time, let's say in the remodeling phase, they might drop all the way back to inflammation. Or maybe the patient has another injury to that wound in the remodeling phase, they might go all the way back to hemostasis. So even though the stages are very organized, just keep in mind that the wound can progress backwards or even move forward in most cases. So let's take a look at the 4 phases of wound healing, because what I really want you guys to see is that even though they're very linear, there's lots of overlap between the different phases that we're going to talk about in the next few slides. So we have phase 1, which is hemostasis, most often occurs between days 1 through 3. And this is a big attempt for the body to just stop the bleeding that has actually occurred, right? That's it. That's the major role of this particular phase. The inflammatory phase is the second stage of wound healing. And it too, like hemostasis, begins right after the initial injury, in particular, right after the initial injury to specific blood vessels. That's going to be the biggest trigger for the inflammatory response. Most often it occurs at day 3 and goes as long as day 20. And then we have the proliferation and what we would call is or granulation phase. And this is the phase where you have wound healing occurring and you have the laying down of new tissue, particularly collagen within the extracellular matrix. And then last but definitely not least, you have that remodeling or maturation phase, which is where the collagen is getting stronger and the body is ready to return to its normative state, whatever that is for every patient. One of the things that I want you to see here, as I said before, yes, very succinct in terms of the phases, but certainly there's overlap in each of these different phases of healing. So our first phase of healing is going to be hemostasis. And the biggest thing with hemostasis, if I could define it for you, I would say it's the process of the wound being closed by clotting. The other way that I like to think of this is it's the body's attempt to kind of wall off and isolate the actual injured site, right? Hemostasis is going to start right when the blood leaks outside of the body. There's this triggering that happens, right? So the first step in hemostasis is really this concept of the blood cells vasoconstricting to restrict blood flow to that particular area, right? That's the body's natural response. I have this external wound, blood touches the external surface, and then we have the process of hemostasis starting. The first step in hemostasis is going to be vasoconstriction, the attempt to kind of, I would say, control the area or isolate the injury. And then the next thing that's going to happen is we have these platelets. These platelets start to infiltrate the area. They start to stick together to also seal off the area and create this wall in essence, right? And then the other thing that we see happening is coagulation, which is going to occur simultaneously with the platelets kind of sticking together. And what this does, that coagulation, it really reinforces the platelet plug with threads of fibrin. And so they're like this that fibrin is like the binding agents for that particular wound. And as I said here, fibrin provides that structural support or really the binding or the sticking component of the platelets. One thing to keep in mind, it starts immediately after the injury. Once that blood touches that external skin, and it's going to continue for about 3 days. But the major thing here is this is the body's attempt to wall off the injury. We vasoconstrict, those platelets start to stick together. We have fibrin intermeshing in between to make this tight structure. And so what we're trying to do really is wall off that injury. And the cool thing is that when we think about fibrin, it just creates this mesh, which again walls off the injury, and hopefully that allows for the wound to be healed much quicker. So that is hemostasis. Then we have the inflammatory phase, which is the second stage of healing, right? It begins kind of right after the injury, or at least within the first 6 to 8 hours. But particularly occurs when we have injured blood vessels, right? And those injured blood vessels start to kind of leak into the extrastitial space or interstitial space or into the tissues. And so we have the signs of inflammation, which for some would be swelling. It could be pain. It could be heat, right? All of those things would be signs of inflammation. But what we typically see is that, okay, we have these injured blood vessels. We've walled off the area as much as we could in hemostasis. However, some of those vessels have been allowed to leak into the interstitial and extrastitial space. So as a result, we start to see like a swollen joint, for example. What is interesting about the inflammatory phase is that during this phase, what we typically see are damaged cells and pathogen and bacteria. This is the time that those key anatomical structures are going to be removed from the wound area, because we have these neutrophils in these macrophages, these white blood cells that come in and start to really clean up the area, right? And this is an important component because this is where we start to see kind of phagocytosis starting to occur, but it's also where we see an increase in what we call is cellular metabolism. Because the white blood cells are working so hard, there's an increased demand for oxygen. So oftentimes this is the time in the injury where the wound will need the most oxygen, which is why it's so important to, in our primary wound closure technique, to close that wound before the first 6 hours, because after that there's this increased need for oxygen, and then more cells start to die off. So if you're thinking about that primary wound closure technique, really want to get that in within the first 6 hours so that we don't have to compete against that increased cellular metabolic demand and the cellular metabolic need. So ultimately, if I could summarize the inflammatory response phase, what I would say is we have blood vessels that are injured. As a result, their contents start to leak into the interstitial and extrastitial space, creating an inflammatory response phase, right? We all know what inflammation looks like. It can look like a big joint, right? It can look like the patient feeling pain. It could feel like a warm joint, for example. But the beauty of the inflammatory phase is it's important. It allows the body to know that something's wrong, right? It's one of our first triggers really in this process. In addition to that, it's where phagocytosis is happening, where the cleanup of the wound is actually starting to happen. And we're also thankful for phase 1, which is hemostasis, where we've walled off the wound and it can't spill out into other tissues that are healthy. The next phase is going to be the granulation or proliferation phase. And this is really the wound healing part of wound healing. If we had to give a phase a name, I would call this the wound healing part. What we start to see in this particular phase is that the new tissue is going to be starting to develop. We have the rebuilding of that extracellular matrix that has been damaged as a result of the actual wound opening. And so in this phase, what we start to see is the wound starts to contract and starts to get smaller because new tissues are starting to form, right? So we have tissue starting to form or lay down, but in addition to that, we have our blood vessels that are starting to kind of heal itself. And now at this point, in phase 2, we were oxygen deprived. And now in phase 3, or phase 3 of healing, what we're starting to see is our new healthy cells are starting to receive sufficient oxygen and nutrients. And so this creates a healthy environment, right, for wound healing. So this is a beautiful phase. This is the phase that we want to get to. But of course, we have to get through hemostasis and we have to get through the inflammatory phase. So the granulation and proliferation phase really consists of several different other phases. The first is fibroplasia, which is the replication of fibroblasts. As the name implies, fibroblasts are tissue building structures. So they're going to be most responsible for laying down what we call is a type 3 collagen, a very weak-like structure. So at this phase, the tissue is very weak and not as strong as its most healthy state, right? In addition to that, we have the extracellular matrix deposition being formed. So this is where those fibroblasts are starting to secrete that type 3 collagen. They start to lay down the collagen. And then what we start to see is that wound start to close and start to get smaller and start to come together, right? And I think that's one of the things that is interesting. So in clinical, if you have a wound, take pictures of it every single day. And what you will start to see is that matrix deposition. You'll see that process of matrix deposition where that wound starts to get smaller and smaller and start to close. And that's because those fibroblasts are laying down that type 3 collagen over time. We also have the process of angiogenesis, which is the growth of new blood vessels, new capillaries in particular, which is important, right? Because as we talked about this concept of having oxygen being brought into the area to create a healing environment, the process of angiogenesis allows us to do that. And then we have epithelialization, which is where those epithelial cells respond and they increase mitosis a few cells away from the wound edge. And again, if our epithelial cells respond, we create this extracellular matrix that's stronger than it was in phase 2, but not as strong as our healthy tissue. So we're looking at about 60% of tissue strength at this point in the game. And then our last phase that we're going to talk about is going to be phase 4, which is going to be the maturation phase. But before we can get there, one of the interesting things about open wounds, I think it's always been said that we should dry out open wounds. But in fact, one of the things that we're learning over time is that we should keep open wounds moist, believe it or not. So we use these wet to dry dressings. And apparently what this does when we work on keeping the wounds more moist is it helps create what we call as mycodebridement. So some of those pathogens will stick to that wet dressing and then we'll remove it indirectly. And then in addition to that, when the wound is moist, it creates an optimal healing environment as well. Now, we're not saying put a ton of Vaseline within the wound, right? But certainly keeping it moist can capture some of the pathogens that might still be present from that open wound. So let's go to phase 4. Phase 4 is the remodeling phase. And if you couldn't tell in that chart, it's the longest phase. So it's where we start to see that type 3 collagen, which is weaker, turn into a type 1 type collagen, which is represents the tensile strength of the uninjured collagen before it was actually injured. So we have a type 3 collagen moving into a type 1 collagen. And this is where we see the wound is completely and fully closed, which is beautiful, right? Because at this point, now we're ready to return to sport. We're ready to return to play. We're ready to return to activity. And so the collagen is deposited in the wound. It is stronger than it's ever been. Most often what we say with wounds, however, is that most wounds never get back to 100%, but we're happy if we have 80% of the tensile strength of the original skin or structure. So our goal is to get it to at least 80% of the tensile strength. But what we know about wounds is this very fact that they're most often more susceptible to re-injury because of the fact that we may not get to 100% of healing. But in phase 4, what we typically see is the transition of type 3 to a type 1. What we see with remodeling is that it begins at about day 21, give or take, but it can last for a year or more, depending on. In ACL injuries, we see it lasting even longer than that, sometimes 2. So you just have to be careful. Big thing is that healed wound areas continue to be weaker than uninjured skin. And again, only having about an 80% of tensile strength when compared to unwounded skin. So we have to work with that. We have to strengthen the structures around that particular wounded area to take up for the slack that might be missing. So those are the 4 phases of healing, right? One of the things that I mentioned in the inflammatory phase is this concept of hypoxia or the lack of oxygenation in an injured area, right? One of the things that's extremely important for wound closures as you consider this is that the rate at which a wound will heal itself is most often extremely important. And one of the biggest key factors determining that is going to be the amount of oxygen in the actual area. So if we have impaired perfusion and oxygenation, then that reduces the healing time, increases the healing time. We have to create an environment. We have to create a healing environment that allows for oxygen to easily infiltrate that wound. So I'm going to say this, and then we'll see it in lab. When you're suturing, we want to approximate. We don't want to strangulate. Oftentimes we'll see those. Have you ever seen sutures where they're so tight they make the skin kind of pinch up? That's strangulation. What we want to do is bring the edges together. If we've done that, we still allow oxygen to enter into the wound. But again, this is an important technique that we have to talk about when we're talking about with suturing, because if we strangulate, we don't allow for perfusion and oxygenation. We don't get nutrition and our cells start to die and our wounds take longer to heal. Oxygenation, perfusion, and nutrition are extremely important to the rate at which we see a wound heal, to the length of the time that we'll spend in each of those phases of healing over time. So as you're suturing, make sure you're not pulling it so tight that we strangulate and don't allow perfusion, oxygenation, and nutrition to occur. So as we get ready to look at wound care, preparation, and evaluation, there are things that we have to consider as athletic trainers, right? And I'm sure you're looking at this list and you're going, yes, yes, check, 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 right? So ultimately what we want to do is kind of look here first. One of the things that we have to There's a checklist of questions that we want to ask. What was the mechanism of injury? Remember, how old is that wound? Remember that primary wound closure happens immediately after. That secondary wound closure is really not going to happen, right? We're going to allow that wound to naturally heal itself. But that tertiary wound, remember, we have between 3 and 5 days to actually close that tertiary wound once it's experienced some healing there. So again, wound age is going to be very important. Anything outside of 5 days or so, and then we're typically looking at that secondary wound closure healing kind of process. We also want to consider the degree of the contamination. That's a big component, like what's in the wound at the time of the injury. If the wound is relatively clean, we can flush that and then we can do a primary closure. However, if the wound, for example, has some type of contaminant in it, then we have to allow that wound time to kind of heal, allow phagocytosis to take over a little bit, and then consider closing that wound. That'd be like a tertiary type of a wound closure technique. Whether or not there's a presence of a foreign body, which again is going to go and be linked back to that third bullet point, right? One thing to also consider is the wound depth and size, and whether or not you're even going to refer it out for suturing, or whether or not you're actually going to suture the wound. So traditionally speaking, we would say that cuts longer than about 1/2 of an inch typically require sutures, and then cuts on the face, however, that are longer than 1/4 of an inch, so smaller cuts, we want to close those because they're going to be more cosmetic, typically require sutures. And then ultimately what we typically would say with cuts on the face is that we actually want to use some type of glue, Dermabond, etc. On the face where we can, of course. And so those are the things that we want to kind of consider. The other thing that we also want to think about is presence of neurovascular compromise, and that'll be linked to diabetes in just a second on this side. And then whether or not there are injuries to adjacent structures. So an example would be in a compound fracture. Obviously we have the wound that actually needs to be closed, but then we have the fracture that has to be reset, potentially the surgical intervention to put the bones back together, right? That would be an example of an injury to an adjacent structure. So I want to kind of go back to this presence of neurovascular compromise, and I want to talk about risk factors that can affect wound healing. So number one, the location of the wound. We know that joints that bend more often or under flexion and extension, and oftentimes will require longer to heal because they're moving more often. And an example of that would be the fingers or the hand, the toes, and the feet. And then in addition to that, any wound within the actual elbow joint as well. So where we have limbs that are going to be moving, more often times than not, that is going to increase the healing time of a wound. Just keep that in mind as you're thinking about whether or not what type of wound closure technique to utilize. And then there are these risk factors that we have to consider. And risk factors are just that. They are things that might impede the healing process of a wound. And to talk about diabetes, because that's a patient population that you'll work closely with, particularly adolescent diabetic patients. Typically they have less blood flow in most areas. And so as a result, if there's less blood flow, there's less platelets, there's less oxygen being administered to the site. Therefore, it reduces the healing, the ability of the body to heal, or increases the healing time. And then we have this concept of smoking, which I think is an important historical question to ask. But from a physiological standpoint, the research has suggested that patients who smoke typically have suffer from longer healing times after a wound closure technique. One of the reasons for that is, believe it or not, smoking limits the amount of oxygen available to the injured site. So when you think about a patient who has a habit of smoking, someone who's a daily habitual smoker, they have less available oxygen available to the injured site. And obviously, as a result, if there's less oxygen available, healing can't always occur. We also know about patients who smoke is they are at an increased risk for infection. And we're going to talk about dehiscence in just a second, where the wound actually reopens. So they have a higher rate of wound dehiscence or wound opening. And we can keep going in the list, but we can see that each of these risk factors, mostly what we're thinking about are individuals who either have the inability to deliver blood to the new area, the inability to deliver oxygen to the area. Anemic patients might have an issue with their ability to bring in fibrin to create and wall off that particular injury. Anything that's hypoxic in nature will reduce the amount of available oxygen available to your patient, in particular to that wound site, to be able to heal. We have to understand these concepts. Over here, we have to be asking ourselves these questions as we get ready to decide what type of wound closure technique we actually want to use. So there are two different kind of types of wounds, I guess, per se. One's going to be an acute wound. One's going to be a chronic wound. So if it's acute, it's something that's traumatic. You have a sudden loss of that anatomical structure or inability to use that particular anatomical structure. And one of the great things about the acute injuries is they go through those 4 stages of healing, right? You have hemostasis, you have in the inflammatory response, you have that proliferation phase, and then you have the maturation phase. And typically, unless we go backwards or forward, those 4 phases are always going to kind of be very linear in nature and sequential in nature. In general, with an acute injury that does not involve bone, that only involves tissue, we're looking at about 6 to 12 weeks for tissue healing to occur. And so most surgical wounds, right? So let's say we have a patient going in for some type of surgical procedure, whether that be like an ACL, for example. Anytime we create an incision, that's an acute pathology. So what we're going to deal with most often in the field of athletic training are going to be those acute wounds that occurred acutely in some way, shape, or form, and wounds that are going to go through the 4 stages of the healing process. On the other end of that, we also have pathologies that create what we call our chronic wounds, and wounds that are going to be more difficult to care for, wounds that may not follow the common progression through the 4 phases of healing. And those wounds, the one that I think about the most are pressure ulcers, particularly in post-op patients who are laying on their back in a supine position, or those patients who are at the end stage of life, right, and are in hospice care. So these are going to be chronic wounds, right, that may not be able to be closed per se. Diabetic wounds are very similar to pressure ulcers in that they have these either superficial wounds and even partial wounds that take a very long time to heal because, again, there's a lack of blood flow to the area. There's a lack of oxygen, which delays the healing process. So in the chronic phase of life, we have a slowing down of the progression of the 4 phases. And most often that patient gets stuck in the inflammatory phase, the phase where you have injury to typically the capillary or the vascular structures, and those structures just continue to leak out into that interstitial, extrastitial space and create this inflammatory response. We have a lack of oxygen, a lack of phagocytosis, so we're stuck in this particular phase for longer than we typically would be. These chronic wounds are very hard to close per se, and most often we're going to treat them with that secondary closure technique where we try our best to allow them to heal, to create this optimal environment in hopes that the wound edges will come together without intervention from some other type of wound closure technique, such as suturing, such as dermabond, for example, or steri-strips. So the question is always to suture or not to suture. That's kind of the question in the field of athletic training. And so here's kind of an evidence-based approach to whether or not we should suture and or not. But when we think about sutures, most often they're used for primary closure, right? So immediately after the injury, go to the ER, get sutured within 6 hours, right? There are times, again, where they could be used in the tertiary closure setting, right? 3 to 5 days later. But for the most part, sutures are going to be used for primary closure, which means immediately, right, you guys? So then next is the Langer lines, and you can kind of see these Langer lines right here. We're using the face as an example, but the entire body has a map of Langer lines. Look it up if you're very interested in that. When we think about Langer lines, these are called skin tension lines or lines of cleavage, however you want to think about that. Essentially, these lines are representations of the direction of orientation of the underlying collagen fibers, particularly in the dermis portion of the skin. And so what they say about this in medical school is that if the skin is disrupted parallel to the long axis of the Langer line, then the wound ends tend to approximate better or tend to heal better, if that makes sense. And they're very good for primary wound closure. However, if the wound occurs across the long axis of the fibers perpendicularly or at a 90-degree angle, then typically the ends don't approximate as well, and that wound might gape open or might not heal well unless the sutures are placed appropriately. So these are things to kind of consider as you're suturing. Does the wound occur parallel to that Langer line or perpendicular to? That's going to help decide how deep you want to suture. Remember, I talked about epidermis and dermis create the strength and stability and alignment, whereas the muscle and the subq going to be really good for creating that cosmetic look. And then you want to consider the age of the wound. Most often what we want to know is is the wound clean? Is it uninfected? And then how long ago did the wound actually occur? The recommendation, like in terms of research, really is that in general, wounds that are less than 6 to 8 hours old, that are clean and uninfected, you can still suture with a primary closure technique. So that's considered primary closure. Remember that. However, there are some areas of the body, vascular areas such as like the face and the head, or the scalp, for example, that would still be considered viable for primary closure within 24 hours of the actual injury. But again, one of the things that we have to consider is patient to patient, how well are they recovering from this? And in this primary closure phase with face and scalp, we have to also take into consideration there's no signs of infection, the patient is healthy, and the wound's going to be easy to suture and or staple. So to suture or not to suture, that is the question. Contraindications to suturing. Lacerations for which suturing will increase the risk of infection. So big, deep puncture wounds, for example. This is where you probably want to use that secondary wound closure technique where you're allowing that wound to kind of heal itself, right? Wounds with debris that cannot be fully irrigated. And the reason we say this is because if we close it with the debris in there, then we increase the risk of systemic infection, which is something that we don't want to do, right, you guys? So consider that. And then superficial wounds that would be expected to heal without scarring. So if it's an epidermal layer, then maybe we do a steri strip for wound closure, right? Other things to consider: dog and cat bites and human bites. And the reason for that is because all kinds of bites carry a lot of bacteria. So there's an increased risk for infection. So we want to be careful not to close the wound too soon. This is actually dog and cat bites and human bites. Most often are typically set up for what we would call is the tertiary closure, right? Because we want to give that wound enough time to heal a little bit, to fight off the inflammatory response, maybe even put some antibacterial medication in the wound, and then close it once we've ensured that all of the bacteria has been removed from the bite. Other wound closure types and techniques. I think these are the ones that we'll see most commonly used within the field of athletic training. Dermabond is probably one of the more newer forms of wound closure technique. So Dermabond is like that glue that's being used in most ERs to close wounds. These are going to be smaller wounds when compared to larger. They're going to be more superficial wounds. So injury to the epidermal layer, for example, would be an example of this. And there are some advantages to using Dermabond over traditional suturing. And one of the advantages is it's antimicrobial, but the other is that it's less traumatic, particularly for pediatric patients. When you have a pediatric patient and they have facial wounds, the recommendation is that actually Dermabond is an even more effective way to close off the wound. But in general, what we see with Dermabond is that with deeper wounds, as long as the sutures occur in the subq and muscular layer, you can still Dermabond the superficial layers and have a really good closure technique. So Dermabond has been probably one of the more accepted methods of wound closures in the last 5 years when compared to the traditional suturing technique. It's less invasive, right? So patients want this most often. And then next, we have staples. Staples are Great for the scalp. That's typically where we see staples occurring most often. We've certainly seen it in the abdominal region, sometimes after an emergency cesarean section, but most often it's usually scalp lacerations. One of the great things about staples is it creates a great tension. And so you get a better approximation of wound edges, particularly in the scalp where the tension is just so high. But it does increase the scarring. So one of the things you have to be worried about is we want to do this in an area that can be hidden. The scalp is an example of that. Hair is going to grow in that area, and so it can be hidden. If you think the patient's going to have a CT, then a staple is not something that we'd actually want to use. And then the removal is the same as sutures. You're just going to pluck it or pull it. Even though it seems like it'd be more work, it really, truly is not. And then we have steri strips. We want to do these in very superficial wounds and very low tension areas. So we wouldn't do this in the fingers, or we wouldn't do this in the foot, maybe like on a forearm, for example. The removal is the same as sutures. You're just gonna, actually easier than sutures. You're just gonna pull those off. Most often in most patients, they fall off in about 5 to 7 days if they've been taking care of them. With elderly patients, you want to be careful because their skin is very thin. So as you're pulling those off, that is one contraindication. The other thing that we talked about, I haven't defined it yet, but dehiscence, which is this concept of the wound gaping back open or spreading wider. And so we do have a higher risk of wound dehiscence with steri strips because they just aren't able to maintain tension, right? So we want to be careful to only use these in low tension areas. These are obviously probably an athletic trainer's dream for closing wounds. One of the things that I think is great, if nothing else, is we can close the wound with the steri strips and then refer out to the ER for a true primary closure technique and suturing. Okay, so what do we do for post-suture care? I think this is where we come in the most in terms of we are able to remove sutures. So in terms of suture care, most often an antibiotic ointment is placed on a gauze pad and placed over the sutures for a couple of days, and they call that a wet to dry dressing. And then we usually try to keep the wound dry for at least 48 hours. So no showering, no submerging, I guess I should say, because what can happen, water can get underneath the skin and create dehiscence all over again. And then for suture removal, if we do it too early, we create that dehiscence I've been referring to. So we want to use this chart kind of as the gold standard for when to actually remove suturing or staples or steri strips from certain areas, right? Those high tension areas are going to require longer time to create healing and to make sure that wound is stable. Your low use areas, right, going to require less days. One thing about suture removal is in general is making sure you're putting on daily sunscreen so that when you take the sutures out, you don't have those like kind of lighter spots in the area of the suture. And then last but not least, vitamin E oil helps with wound healing and also helps with reducing the scarring look effect. So this is wound dehiscence. You guys can kind of see that there, opening of the wound closure along the surgical closure technique. So we want to make sure that we are doing everything we can to reduce wound dehiscence. Obviously, there are risk factors that increase the risk of developing wound dehiscence. Some of those are going to be diabetes and obesity because there's so much tension from the weight. But this other risk factor is Ehlers-Danlos disease, syndrome, which is really a connective tissue disorder. So they're more often at risk for developing wound dehiscence. And then you have abdominal dehiscence, right? Which is opening of a wound on a fascial closure. So an example of that would be what? A cesarean section, right? So here's an example of maybe an abdominal wound opening, and you can kind of see that wound dehiscence there. In addition to wound dehiscence, we also have pressure ulcers, which remember I said is a chronic wound that really stops the progression of healing within that inflammatory phase. So we have to be careful because what we know about ulcers, in particular pressure ulcers, especially those that are on hospice, is that they develop this wound, and most often you have skin death occurring, which is called pressure necrosis. there's less oxygen being delivered to that area. And so then the biggest thing with this is there's delayed healing. And so that patient is at an increased risk for infection. So certainly isn't something that we could use a primary wound closure technique on. Probably something that we'd use a secondary technique on, where we are allowing the wound to heal itself over time and protecting that wound while we possibly can. One way to avoid pressure ulcers in our elderly patients or hospice patients is to actually roll them over onto different sides, their stomach, their back, often to avoid the development of pressure ulcers in general. So there are two disorders of scarring, hypertrophic versus keloid, and I want to talk about them because they are different, even though they're always referred to as the same thing. So when we think about hypertrophic scars, these are scars that are raised and thickened, but they are within the actual scope of the suture. So we'll see that here. It's very raised. Most often, we think about hypertrophic scars, we don't really have to do anything to treat them. If they're hypertrophic, typically they will go away as the inflammation reduces over time. So there isn't much that we have to do for them, right? But people oftentimes get that confused with keloids. When we think about keloids, those grow beyond the margins of the original injury or the original scar, right? Whereas with hypertrophic scarring, it doesn't grow outside of that margin, but the keloids, they do. So when we think about a keloid, it's more of a tumor that arises from this connective tissue in the dermis, right? And it is caused by overproliferation of fibroblasts within that proliferation phase. Most oftentimes, keloids will present to you at about week 1 or so, and you'll start to see it develop there. There isn't anything that you could do treatment-wise that to cause improvement, right? And so this would be an example of a keloid. We know that African Americans are pretty prone to the development of keloids over time. So how do we prepare to do wound closure? First and foremost, we want to make sure the patient is comfortable. We want to inspect the wound. If we see anything in that wound, we want to irrigate it, want to control bleeding. And then the next step is we want to kind of inject an anesthetic around the wound, especially if we're getting ready to suture like traditional suturing. In terms of treatment of keloids, the real true only way to remove that, and that isn't even to guarantee that they won't come back, is usually like some type of laser or radiation therapy. Clinically, I've seen this done a few times with student athletes where they actually inject cortisone directly into the keloid, extremely painful, and over time it causes the keloid to shrink. But a patient who suffers from keloids most often will continue to suffer from them. So like piercings, for example, would not be recommended in a patient that we know has suspected keloid issues. So remembering the goals, back to this, what are we doing it for? Is it to control bleeding? Is it to facilitate faster healing, to decrease the chances of infection, or to minimize scarring? Like, what's the goal? Okay, surgical suturing principles, length and direction of incision. We talked about Langer's lines and following the normal wrinkle lines of the skin wherever possible. Always want to kind of create a suture technique that's going to be parallel to those Langer lines. We have to make sure that we are careful when we are working with the tissue. So we're wearing gloves, we're creating a sterile environment. We have to remember hemostasis, that there's a process where the platelets are coming together and they're getting sticky, and fibrin is creating that mesh, and we don't want to disrupt that. Wherever possible, we want to remove any kind of dead tissue or foreign material using a debridement process. And then remember, when we close, we want tension, but we don't want to strangulate the area. So there are different types of closure. You guys will not be able to do a multi-layer closure, but you will be able to do a single layer closure, which is most often associated with the superficial and partial thickness wounds, right? The wounds that involve epidermis and dermis. Anything deeper than that, multi-layer, is going to involve some type of surgical technique where the patient may actually have to go under. All right, so when we think about closure techniques and suturing techniques, we have simple interrupted sutures, which is what we're going to learn in lab. We have the staples, we have steri strips, and we have some type of tissue adhesion, that's dermabond, right? So what do we need to suture? We need some sort of anesthetic. You cannot suture a patient if you do not inject them with some sort of pain medication, okay? We want to, after doing the sutures, we want to make sure the patient's tetanus is up to date, and then we need materials and a suture kit. So we're always going to have a suturing needle with a suturing thread of some sort. We're going to have scissors to cut. We're going to have a hemostat, and we're going to have forceps, and then in addition to that, we'll have a scalpel, and we'll talk about what the scalpel is for. So suturing basics. For acute injuries requiring suture repair, a few recommendations will hold true most of the time. We always want to use an interrupted knot technique. So you can see there's 5 different sutures in this image, and that's what we'll learn. You want to use non-absorbable sutures for the most part. Absorbable ones may be deep, but superficially we like the non-absorbable ones, and so we can take them off. And then remember, approximate, don't strangulate. And when we prepare the wound, one of the things that we want to do is anesthetize. I'm not going to spend a whole bunch of time here because the reality is we don't do this in the clinical practice unless we're a PA, nurse practitioner, or a doctor. But someone will anesthetize the skin, someone will debride the skin, and then once we're done debriding the skin, we will then move into deciding what type of suture we actually want to use. We can use a non-absorbable or an absorbable suture. Again, I said for deep wounds that involve sub-Q or muscle, we want to use the absorbable suture. And then for partial thickness or superficial thickness tears, the non-absorbable sutures work just perfectly. They also work very well for low tension areas. I think I said that. So I apologize if I'm repeating myself. So we can see the non-absorbable and absorbable have play different roles in the human body. It's very rare that you're going to see an absorbable suture on the superficial component of the skin. Most often if we see sutures externally, they are non-absorbable. Suture size is also going to be another component that we talk through in the lab, but you can kind of see in areas where there is a lot of movement, you're going to have sutures that go up in size, and then where there's less movement, lower suture size, and this will be important as well. So we will go through this in the lab, but a couple of things that we want to talk through just really quickly in this video is this is the needle, and there is proper needle holding technique and improper. So improper would be holding it too close to the hook or holding it too far away from the hook. You want to be somewhere in between, somewhere in the sweet spot of the J or leg component of the J. And you'll get used to this. You'll be using your hemostat here to hold that needle and thread it through. Let me see if I can get this video to play for us really quickly. So what I want to show you is as she goes to pick up that needle, right, you will see in just a second how she's holding that needle somewhat in the middle of that. And that will become important when you start to hook through the different tissues of your patient. If you hold it too close, then you'll have to adjust while the needle's in the patient, and it becomes very uncomfortable. So we'll work on that and work on threading and getting used to holding it so you can see what the proper technique would be. And then I already talked about this. We're going to be doing what we call our simple interrupted sutures. Simple interrupted sutures are probably the most common clinical practice for sure for clinicians. And so you'll see them thread it through. And then you'll see them grab, let go, and then grab, and then pull the needle through. And then that's where your rat tooth is going to become important. And they'll thread it through again to the other side. And then what you're going to see in just a second, I'm going to speed it up just a little bit, is the knot tying technique. And again, we'll go through this. But what's a simple interrupted? It means every suture we tie a knot, cut the loop, and move to the next suture. And this is a pretty hard or difficult technique because you have to make sure your sutures are aligned. And that's going to be a big component of this. I'm going to skip just a little bit so that you can see. They're using the tying technique. So when they're done, what you're going to see them do, I think, is create what we call our simple interrupted sutures. Are you guys seeing that there? Each time we finish a knot, we actually cut. You can see the tail of the knot is long because when we go to remove them, we want to make sure they're a little bit long, right? So you're going to leave that small tail. and then each suture is cut before a new one is started. And we want to make sure that we approximate and we do not strangulate the wound, right? So the interrupted suture really provides a more secure closure, even though lots of people love the continuous suture, which will be on the next side. The other thing it allows you to do is if there's an infection in part of the wound, you can remove just those sutures, clean, debride, and add those sutures back again. So the interrupted suture not only creates a stronger wound closure, but allows you to work within segments. We have this running or continuous suture. So as you can see here, you never cut, and your knot is at the beginning and at the end. So it's a series of stitches taken in one strand of material, leaves less foreign body in the wound, but it can transmit infection along the entire length of the strand. So yeah, maybe you remove some of the material, but if an infection occurs, it occurs across the entire strand. Whereas with that interrupted suture, it's only going to occur in that particular suture. So you can take that out, treat it, and then add it in again. That's why interrupted sutures are probably the preferred suture type and technique. Here we see stapling. Most often, as I said before, stapling is going to occur most often over the scalp. And so we want to do it in areas where it can be covered. I mean, this isn't a great stapling technique. Can you see kind of how crooked that staple is? You see inconsistencies in the width at which we're starting to see skin dehiscence here. So we'll talk about stapling a little bit. And I think we have a few staple guns for you to play with. When you remove staples, it's like using a staple remover. So we'll talk about that. It'll start like this and it'll end like that. So we are going into suturing in the lab. I hope that you watch this lecture, at least understand the reasons why we do suturing, because they're extremely important in clinical practice.